So in this video, we shall be doing a rapid revision of the subject of radiology. So this is meant for the exam going students who are appearing for the PG entrance examinations. What I would personally recommend is combine this particular video with the snapshot video, alright. So see both of them such that you have a good grasp of the subject, particularly the images. So most of the questions that you now expect from the subject of radiology will be clinical vignettes. So they'll give you a clinical scenario and they'll have a radiological image which is attached with that, and you'll have to either make the diagnosis or suggest the next step. So those are mainly the kind of questions that you now expect from radiology. So you have to be very confident about the images. In addition, radiological anatomy is again something where you have to pay extra attention because you get tested a lot, particularly the FMG students. You always get questions from radiological anatomy. That is also something which is very important. In particular, as far as systemic radiology goes, emergencies in general are going to be very important, alright. So always pay extra attention irrespective of the subject, that emergencies are going to be a major testing area for you guys. And finally, just to conclude, what I would like to tell you how this video is designed is, first we shall be looking at general radiology, then we'll look at systemic radiology, and finally we end with nuclear medicine and radiotherapy. So general radiology, you get questions which are quite direct and one-liners, right? So in case you get these questions, do not miss out on them because those are easy marks for you. Okay, so just we'll go through the general radio portion quite quickly, and then we focus mainly on systemic radio where you get a major chunk of your questions from. And radiotherapy, nuclear medicine, just like general radio, you get a few one-liner questions which are quite high yielding and scoring. Okay, so that should be your approach for the last minute revision. In addition, one more video I would recommend you to watch is the thumb rules video, wherein I want you to just go through that video very quickly, maybe on 2x, such that you are able to grasp that concept of when to do which investigation, so that you get a lot of such questions wherein they'll give you a scenario and they'll ask you what will you do next, how to approach the patient. So when to do which investigation is again conceptual. I don't want you memorizing lists about which is the investigation of choice, which is the gold standard. I want you to have the concept of logically solving these questions of when you would want to do which investigation, right? And the thumb rules video will definitely help you do that, right? So that is how you should now base your preparation. After all of this, let's begin a rapid revision of radiology with general radio. So the first thing that we want to do here is look at the names of the scientists very quickly. This is something, again, you don't get too many questions from this, but just to cover all our bases, we'll be looking at this. So who discovered gamma knife? Remember, it is Lars Lexell who's the person behind gamma knife. So this is the list that we want to look at. So W.C. Röntgen, or Wilhelm Conrad Röntgen, is the father of radiology. Remember, he's been credited with being the father of radiology. He discovered X-rays on 8th of November 1895. This is the only date that I want you to remember, which is 8th of November, because it is celebrated as the International Day of Radiology. It's celebrated as International Day of Radiology, and in 1901 he went on to receive the Nobel Prize for the same. Okay, so this is about Wilhelm Conrad Röntgen. Moving on, Godfrey Hounsfield, Alan Cormack. These are the people who discovered the CT scanner, the computed tomography scanner, which uses X-ray in a 3D manner to take these cross-sectional multiplanar images, right? So this is the CT scanner computed tomography, and based on Hounsfield's name, we also have the Hounsfield unit, right? So you must have read this Hounsfield unit, which is the number that we give to the density of how black or how white something is. That is referred to as Hounsfield unit. Peter Mansfield and Paul Lauterbach discovered MRI, alright. So they discovered magnetic resonance imaging, which doesn't use any ionizing radiation. It uses radio frequency waves and a large magnetic field, okay. Bloch and Purcell are the people who discovered the concept behind MRI, which is called NMR. So this is the concept of MRI, which is called NMR, which is nuclear magnetic resonance. So this concept is based on the fact that all the protons that we have in our body are going to be spinning on their axis like this. Okay, so they're constantly spinning. Now, when I keep these protons, or when I keep the body in a large magnetic field, these spinning protons are all going to now align in one direction. direction are going to align in a similar direction, and this is what helps us generate the MRI signal. Okay, so this concept, which is nuclear magnetic resonance, where we use the nuclear movement of the protons, that is something which is responsible for MRI images without any radiation, right? So remember, MRI, no ionizing radiation. Charles' daughter is been credited with the father of interventional radiology. Alright, so the intervention aspect of radiology, daughter is the father of it. Henry Becquerel is the father of radioactivity. Alright, so radioactivity, you must be aware of this from +2, where he is the father of radioactivity. Lars Lexell is the one who discovered the technique of gamma knife, and this has very high chances of being asked. Gamma knife is a very important topic which we shall discuss in radiotherapy, and this is also referred to as stereotactic radiosurgery. John Wilde is the one who discovered medical ultrasound. He is the one who is responsible for the discovery of medical ultrasound, and Ian Donald is the one who further described obstetric ultrasound. Alright, so he described obstetric ultrasound scans. So these are all the scientists in a nutshell that you need to know in radiology. Going ahead to the next basic concept, which is all of the following investigations use ionizing radiation except. So technetium-99 DMSA. Remember, this is a scan which is used for the kidney. For a morphological static scan of the kidney, we use the DMSA scan. And the fact I want you to remember, anytime we have technetium-99M, it suggests that it's a nuclear medicine scan that uses gamma rays. So technetium-99M releases gamma rays, and do gamma rays constitute ionizing radiation? Yes, most definitely. So this uses ionizing radiation. HSG, hysterosalpingography, wherein we inject contrast into the uterus, into the fallopian tubes, and we see the patency of the fallopian tubes. This is usually done under X-rays, right? So this is usually done under fluoroscopy. This is a video of the X-ray, and we know X-rays are also ionizing radiation. X-ray of the ankle, again ionizing radiation. FAST. So what is FAST? Again, the full form has been tested a bunch of times. So FAST is basically focused assessment. So do not confuse it with the word fast or abdomen. It's not that. It is focused assessment sonography in trauma. Alright, so this is what FAST stands for, and as the name suggests, this is basically an ultrasound technique that we do at the bedside for patients with trauma as a part of their workup in the primary survey. Okay, so this is sonography, and remember, sonography is something which does not use ionizing radiation. So going ahead, in a nutshell, if I have to summarize, there are a whole bunch of things which utilize ionizing radiation. So I might just remember two things which do not have ionizing radiation. So remember, any sort of MRI sequence that they give you will not have ionizing radiation. Any sort of ultrasound mode that they might give you, which is B mode, M mode, Doppler, any of it will not have ionizing radiation. And something just for completion's sake, which doesn't have ionizing radiation, not used very routinely in practice now, is thermography. So thermography is also something which doesn't have ionizing radiation, but no longer used too much in practice. Alright, so these are the things which do not have ionizing radiation. Everything else, which is X-rays, CT scanner, any fluoroscopy that we are doing, or any nuclear medicine investigation is going to constitute ionizing radiation. So now when we talk about what constitutes ionizing radiation, remember we have electromagnetic spectrum and we have the particulate radiation. So out of the electromagnetic rays, we have X-rays, gamma rays and cosmic rays which contribute to ionization. X-rays and gamma rays are what are used for diagnosis, whereas cosmic rays are predominantly what constitutes the background radiation, right? So this is not something we use for diagnostic purposes. Particulate matter, we have alpha, beta, proton and neutrons which all have ionizing radiation, and these will come into play in treatment. They are not used for diagnostic purposes, but they are used in radiotherapy, right? So going ahead, which out of these are the most penetrating rays? So when we talk about rays, remember it's the gamma rays which is the most penetrating radiation. But if your option doesn't include the word rays, if it just asks you what is the most penetrating form of ionizing radiation, remember neutrons have a higher penetrating power than gamma rays, alright. So neutrons do have a higher penetrating power. So let's summarize this with the help of a table. So when we look here, ionization power is the same. Remember, it's the same as linear energy transfer or damaging power. Any of these words are used in the question, they mean the same thing. Or they could ask penetrating power. Alright, so you can have 4 questions being framed from this topic, this table. So what are the particles which have the maximum damaging or ionization power? It's gonna be the alpha particles. Remember, it's gonna be the alpha particles which have the maximum damaging power, and because they are so heavy, do you think they're going to be able to penetrate too much? No. So that is why it also explains why they have the minimum penetrating power, right? So they have the minimum penetrating power. When we talk about maximum penetrating power, I want you to remember that the maximum penetrating power is with neutrons. So here we have to remember neutrons followed by gamma rays depending on the question being asked. And what has the minimum ionization power? It's going to be the gamma rays. Alright, so out of this we have the gamma rays which have the minimum ionization power or damaging power. Okay, so this is a table which is going to be very important for us to remember. Now we talk about ionizing radiation and all the harm and all the damage that it causes. Now what is the mechanism by which it acts at a cellular level? So remember, first mechanism is it causes DNA damage. So it causes DNA damage. Predominantly the most common type is going to be the double-stranded DNA breaks that it causes. Alright, so double-stranded DNA breaks. Apart from this, it also causes free radical mediated damage. Because of all the ionization that is happening, free radicals are going to be generated, and free radical mediated damage is going to occur because of the ionizing radiation. These are 2 mechanisms by which ionizing radiation is going to act, and it's going to be harmful to us. So now let's talk about the effects of radiation. So effects of radiation may be divided into stochastic and deterministic effects. Alright, so how to remember them? So remember, stochastic effects are effects which occur by chance. They are a chance incidents which are not planned. They do not have a threshold at which they are going to act. Alright, so these are side effects which are occurring by chance. So if you remember the examples, other things become much easier to understand. So remember, stochastic is cancer. Alright, so any mutation or any cancer that can occur as a result of radiation is a chance effect. There is no fixed dose at which I will say that this patient is going to develop cancer future in his life. Okay, so this is an event that occurs by chance. It's a stochastic effect. So does it have a threshold? No, there is no threshold here. What is the function of dose? So the function of dose, that what likelihood increases as he receives more and more dose of radiation, is going to be the probability of this developing. So the probability of developing a cancer is going to increase with the amount of radiation, right? So probability is a function of the dose, and is it going to be an immediate side effect or a delayed side effect? So this is going to be a delayed side effect. On the other hand, deterministic effects. So these are effects which can be determined, which we know are going to happen beyond a certain threshold. So effects like erythema, effects like loss of hair, effects like sterility. So all of these are deterministic effects which have a threshold, that beyond this radiation dose you will have these side effects. And as the dose keeps increasing, what becomes a function of the dose? It is the severity. So when you receive more radiation, you will have more severe erythema. If you do not receive so much radiation but have crossed the threshold, you will have less severe erythema. Right? So that is how severity is a function of dose. Timing, this is going to be immediate, right? So this is going to be an immediate side effect that you are going to have. So these are the stochastic and deterministic side effects. Now talking about unit of radiation exposure. So we have these 4 units, and you are being asked which is the unit of radiation exposure. So here remember, it's Roentgen that is the unit of radiation exposure. So this is again something which is a very volatile topic. So this is something that must be revised one more time before your exam. So I want you to put this on a piece of paper or a book wherein you have your volatile stuff consolidated and it goes into your final revision. So all of these radiation units can be divided into the standard international unit and the conventional unit. So we'll have various tricks which will help you remember this. So there are these 5 entities that we need to remember the units for. First is radioactivity. Now, radioactivity is a different concept. It's something that deals with radioactivity, radiotherapy, nuclear medicine. So, we'll keep this separate, and then we have all the others which are going to be dealing with our general diagnostic radiation. Okay, so radioactivity, when I talk about it, the SI unit. So, remember, the SI unit is going to be the father of radioactivity that we've already been through. So, the SI unit is going to be becquerel. So, becquerel is the SI unit of radioactivity, and it's the same. 1 becquerel equals 1 disintegration per second. Okay. Conventional unit, I want you to remember C for Curie. So, Curie is the conventional unit. How are they related? 1 Curie is equal to 3.7 into 10 raised to 10 times becquerel. So, this is much higher. Okay, so you can remember females have much more power than males. So, you can remember it is 10 raised to 10 times the power of becquerel. Okay, so now going ahead. So, it's not meant for any offense to be taken, just a joke and a trick to remember, right? So, now talking about the units of radiation related things and how it's going to affect. So, the very first entity, which is the exposure, which describes that the moment radiation is released, how much is the ionization it does to matter. Okay, so exposure SI unit. So, if you remember ionization per unit matter mass, we'll call it Coulomb per kg. Alright, so the SI unit is Coulomb per kg and the conventional unit. Now the trick begins. So remember here that for all conventional units, for X-ray related stuff, for all the upcoming entities are going to be starting with an R. So all of these are going to be starting with an R, which is conventional unit. So here, because it's the first thing that X-ray is doing to the mass. So the conventional unit here is going to be Roentgen. So Roentgen is the conventional unit of exposure. Now going to the next thing, which is absorbed dose or the air karma. It's also referred to as air karma. So as the name suggests, the moment it goes to the skin, how much is the absorption which is happening. So here remember the mnemonic ABG rad. So remember ABG rad, wherein AB for absorbed, gray is the SI unit, and rad here, R for rad, is going to be the conventional unit. So ABG rad, gray and rad. Finally, we have two entities. First is the equivalent dose. So now here we are basically equalizing all the radiation by a radiation weighing unit. So we have seen that alpha particles is going to be much more damaging or have much more ionization power than gamma rays. So if I have to basically equalize this, we will be using an equivalent dose term where we'll give it an additional radiation weighing factor. Okay, so that is the equivalent dose whose SI unit, S for SI, is going to be sievert. So this is going to be sievert, whereas the conventional unit, again starting with R, is going to be rem. Okay, same thing, easy, goes for effective dose. Now this effective dose is going to be tissue weighing factor. What is the effect that this radiation has on different tissues is going to be given by the tissue weighing factor. Okay, so here we have the same units, sievert and rem. So when I ask you which is the most useful terms of expression of radiation, it's going to be effective dose. So remember here, this is the most useful. Alright, and I've also given you the conversion factors for each of them, which are not frequently asked, but you can just remember these two. 1 gray equals 100 rad, 1 sievert equals 100 rem. So these are the units that we need to remember. Identify the incorrect pair of maximum radiation exposure limit according to AERB guidelines. So AERB is the Atomic Energy Regulatory Board of our country, which regulates all of these timelines, alright, it regulates all of these definitions of what are the various cutoffs. So here, general public 1 millisievert per year, this is true. Occupational worker 2 millisievert per year, this is definitely wrong. Length of occupational worker is 150, skin is of general public is 50. So let's try and figure out a way to remember all of these values. So this is a table summarizing all the values that have been put up by AERB. So we divide them into occupational workers, so whoever are involved in the radiation technology, whether it's the technicians or radiologists, will be counted as occupational exposure, whereas then you have the general public. So overall for occupational exposure, Remember, the value they have given is 20 millisievert per year when it's averaged over 5 years. So in short, in 5 years, you need to have an exposure of total 100 millisieverts. Okay, that is what is allowed. So when we average it, it becomes 20 millisievert per year. But in one calendar year, it is 30 millisieverts in any single year. So remember this, that you can have either of these two values which are being asked. In 1 year, 1 calendar year, 30. But when you sum it out for 5 years, the total thing allowed is 20 millisievert per year. Public, it's 1. Remember, single number 1 millisievert per year for general public overall exposure. Now we have lens exposure guidelines which are given separately. So for occupational worker, it's 150. Just remove a 0, it becomes 15 for public exposure. A higher cutoff is given for skin and extremities, wherein it is 500 millisieverts for occupational worker, and you remove a 0, it becomes 50 for public. Then when we talk about pregnancy, this is where you get your bunch of your questions from, wherein in pregnant occupational female, remember, it is 2 millisievert per year for a pregnant occupational worker. But when you talk about a general pregnant female, it's the same. It's the same as general public, alright? So nothing different. But in a pregnant female, it is 1/10 of your normal occupational worker, which is 2 millisieverts per year. And the fetus will get 1 millisievert per year here. So the standard rule is fetus gets half the radiation exposure. So if they ask you what is the radiation allowed for the fetus, you say 1 millisievert per year for occupational pregnant female, or 0.5 for public or a standard general fetus. Okay, so these are the values that you need to remember. So now talking about X-ray tubes. So all of the following are true about modern X-ray tube except. So one, rotating cathode is used. No, this is wrong, right? We have the rotating anode. Remember, the cathode is just a filament, which is a thin filament of tungsten which is used, but the anode is actually a disc that is made, which is frequently rotating. Alright, so it's a tungsten disc that rotates. So we have a rotating anode, also called as the target. Okay. Second, target is made up of tungsten and rhenium. So yes, the tungsten here in the target is alloyed with rhenium. Filter is made up of 2.5 equivalent of copper plus aluminium. This is also true. Outer protective housing is made of lead. This is also a true statement. Alright, so this is the wrong statement here. So now let's quickly discuss the formation of X-ray tube. So here, as we have discussed, the outer tube is going to be made up of lead. So this is the outer protective housing which basically houses your X-ray tube, which doesn't allow the leakage of radiation. We don't want radiation leaking from the X-ray tube, right? So all of it is absorbed by the lead, which acts as a protective housing. Now coming to the glass tube per se. So this is the X-ray tube which is made up of glass, which is referred to as Pyrex glass. Okay, so that's a heat resistant glass that you have, which forms the X-ray tube, and you have oil which is circulating. You have oil which is circulating around the glass tube so that some amount of heat can be conducted away. Now we go to the cathode and anode. So here I want you to remember the mnemonic. CT is an art, alright. So interpreting CT is not easy, CT is an art. So cathode and anode, both are made up of tungsten. That is common. Both of them are made up of tungsten, but cathode is made up of tungsten which is alloyed with thorium. So CT, whereas anode is made up of tungsten which is alloyed with rhenium. So ART. So tungsten and rhenium in the anode. Alright, so again, why is tungsten chosen here? Because it has a very high melting point. It can be alloyed into this filament. Alright, and again, it has a very high heat capacity. So that is why it can be used for cathode and anode with some help from the alloys. Okay, so this cathode is the negatively charged filament that we have, wherein you have these electrons which are released. So when you heat the cathode, okay, you have a process called thermionic emission. Thermi means heat, ionic means the electrons are released, emission means they are released. So thermionic emission is the release of electrons from the cathode when you heat it up. Okay, so that is what we are going to be seeing, and when these electrons will strike the anode, being electrons negatively charged, they're going to strike the positively charged anode, and this interaction of the electrons with the anode is going to result in the formation of these X-rays. So this is how X-rays are going to be produced, and these X-rays will now be released from the window. Okay, so this window here is a thinned out glass tube. This is just the glass itself which is thinned here, and that allows the X-rays to escape, and finally before they reach the patient, they are filtered. So the filter here is made up of aluminium and copper. Okay, so this is the filter which will absorb the low energy rays which are not going to do you any benefit but are only going to cause radiation exposure. Okay, so that is the job of the filter. Here you have one more thing, which is the focusing cup. So you have a focusing cup here which is made up of nickel that doesn't allow electrons to go haywire. Okay, it will keep it directed into one streamline which can hit on the anode. So this is the X-ray tube. Just to sum up very quickly, what is the X-ray tube made up of? So it's made up of Pyrex glass. What is the negatively charged cathode made up of? So that's made up of tungsten plus thorium alloy. Anode, or the positively charged target, which is a rotating anode, remember, most commonly, that is made up of tungsten plus a rhenium alloy, right? What about the window? So the window is made up of glass itself. We have a filter which is made up of aluminium plus copper, 2.5 millimeters equivalent. Grid, so there is also a grid which is used behind the patient. Alright, so remember, if this is the patient, this is the X-ray tube which is producing the X-ray. In between the image receptor or the film, we have something called as the grid. So this is where the grid comes in, and it will basically not allow any radiation which is going in an off-focused manner. So anything which is not perpendicular will be absorbed by this grid. Okay, so it basically improves the quality of the resultant X-ray. So it improves the quality, it improves the contrast of the image, but the radiation is also a bit higher. So it also causes more exposure, but in turn improves the quality of the X-ray film. This grid is made up of lead strips. So it is made up of lead strips plus aluminium strips. Okay, so there are these linear bands of aluminium and lead which are separated by each other. The protective housing is again made up of lead which absorbs any stray radiation. Okay, very quickly, mammographic X-ray tube versus normal X-ray tube. So there are a few changes between the two. So in radiography, we have seen that the target is made up of tungsten plus rhenium. Here in mammography, M for molybdenum. Remember, molybdenum is what makes the target. The window in the radiograph was made up of glass itself, thinned out glass. Whereas here, it's going to be made up of beryllium. So it's made up of beryllium here. When we talk about the filter, in radiography, we saw that it was an aluminium plus copper filter. Whereas here, it's again going to be a molybdenum filter. Okay, so you have M and B in mammography X-ray tube. Everything else is the same. These are the only changes that you have. So now continuing our discussion with contrast media. So this is something again very volatile that you must revise right before your exams. Alright, so here I am showing you images of 4 contrast media which are frequently used in various investigation modalities. So let's start here. So in the bottom right corner, what we have here is OmniPac. Now I want you to remember this trade name in particular because OmniPac is one of the most frequently used contrast agents that we use for CT. Alright, so this is actually an iodinated contrast agent that is useful, one, for CECT whenever we are doing a contrast enhanced CT. This is the contrast media that we shall inject intravenously. Secondly, you also want to remember anywhere in an oral study when you have barium which is contraindicated. Alright, so anytime barium is contraindicated, such as when you have a tracheoesophageal fistula, or there is a post-operative patient where we want to see post-op stricture or post-op fistula, again we can give OmniPac. Okay. Apart from this, this can also be used in various investigations such as hysterosalpingography, ERCP, myelography. So in all of these we can use iodinated contrast agents. Alright, so remember OmniPac is what it comes as a trade name. So just remember here one more MRI trade name that we have for an MRI contrast agent is OmniScan. Okay, so do not confuse OmniPac with OmniScan. Apart from that, one commonly used contrast media for MRI is what is called as multi-hands, and H here I want you to remember, it's a hepatocyte specific contrast agent. So this is something which is particularly useful when we are imaging for hepatocellular carcinomas. Okay, so these are all gadolinium based. Alright, so if you see this gadobinate demiglobin, these are all gadolinium chelates. So we chelate the gadolinium ion with various compounds such that it no longer remains toxic. Okay, so these are all gadolinium contrast media which are used for MRI. Okay. Right, what do we have here? We have sonoview. So this is again something which is a very important potential question, which is an ultrasound contrast agent. So sonoview here is an ultrasound contrast agent. The biggest advantage, this is the only IV contrast media that can be safe, alright, which will be safe in patients who have renal failure. So in patients with deranged renal functions, you will have gadolinium which is contraindicated, you will have iodinated contrast which is contraindicated, but sonoview is going to be safe, okay, because it consists of these micro bubbles. It is made up of these very tiny micro bubbles which are excreted through the lungs. So that is why it can be easily given in patients with renal failure. And finally, microbar. This is actually barium sulfate. The barium sulfate that is used for GI studies. So this is used for various GI studies. It is a compound which is not absorbed into the circulation, remember. So we'll administer it either orally or through the perrectal route, and it is never absorbed, alright. So we will see it in the lumen, we will see various pathologies like strictures, like carcinomas where you have irregularity, alright. So all of those of the bubble loops from the mouth to the rectum, we can evaluate using barium sulfate. So now let's quickly talk about barium studies in some detail because you get a lot of questions. So when we talk about barium sulfate and barium studies, there are a few contraindications. So barium is very safe as long as it remains intraluminal. The moment it leaks out into any cavity, whether it's peritoneal cavity, mediastinum, lungs, it will cause a lot of harm. So it causes chemical peritonitis. Alright, it causes chemical peritonitis, chemical mediastinitis, it causes pulmonary edema. So anywhere where you have a risk of leakage of barium, it becomes a contraindication. For example, when you have this, when you have an X-ray wherein you are seeing this air under the diaphragm, this is an X-ray that nobody has to miss in the exam. Air under the diaphragm, right side, this is the first thing that your eye straight away goes to anytime you see any chest X-ray. And remember this rule for life, okay, not just for exams, that this is the first thing you want to rule out, because if this is there, patient goes straight to the OT. And more importantly, it means that there is free air in the peritoneum, there is pneumoperitoneum, and it indicates perforation. And in such cases, barium is a complete contraindication. Similarly, when you see dilated bowel loops, you have a picture of obstruction, intestinal obstruction. Barium is again completely contraindicated. Similarly, in cases where you have tracheoesophageal fistula, do not give barium. In cases of post-operative patients, do not give barium because it can leak out through the post-op anastomosis sites. Alright, so these are the contraindications of barium. Now talking about the various names of barium procedures. So what do we see here? So this is a zoomed image of barium. So here you can see these complete mucosal folds. We see this coiled spring kind of appearance, this concertina kind of appearance. So this is both suggestive of barium meal follow through, which is basically done for small intestinal loops. And these complete mucosal folds, this valvulae conniventis, alright. So when we see these complete mucosal folds, they are referred to as valvulae conniventis, which are a feature of the jejunum, alright. So in jejunum, we are going to be seeing these complete folds, and when we are evaluating the small intestine, we call it barium meal follow through. So we have 4 barium investigations. This is barium swallow, this is barium meal, this is barium meal follow through, and this is barium enema. So for the first 3 investigations, we ask the patient to swallow the barium. Alright, so whenever we are looking at the esophagus, that is barium swallow. When we look at the stomach, that is called the barium meal. when we look at the small intestine, so again, how to identify the parts? There is the duodenum based on the shape, crossing over to the left side at the DJ flexure, something which is very, very important, will be absent in cases of malrotation. And all of these feathery loops that you are seeing, all right, all of these feathery loops, which are because of the valvulae conniventis we just saw, will be the jejunal loops, whereas these loops which do not have any marked feature, alright, or are typically described as featureless, are the ileal loops, right. So this, when we study the small intestine, is barium will follow through. And finally, when I inject the barium per rectally, that study is called barium enema. Now, one concept about barium, it can either be a single contrast barium or a double contrast barium. In single contrast barium, we just give barium alone. So, as you can see here and here, we are only giving barium to the patient. But when I give barium as well as air, so that I get a good intrinsic contrast wherein barium will be white and air will be black, right. So, here if you see that this is the barium and this is the air, basically because of the mucosal coating of the barium and then air distending it, you have this very good mucosal detail. So, that is where we use double contrast, and the advantage is it provides better mucosal detail, alright. So, this is again an example showing you double contrast where you have air also, you have barium also within the lumen. Okay, so these are the two kinds of barium studies that we can do. Going ahead to iodinated contrast media. So, now talking about iodinated contrast media, here the classification is again something that gets you a few direct questions. So, you can have ionic contrast media or non-ionic contrast media, which are further classified into monomers and dimers, Alright, so now when we talk about osmolarity and iodine particle ratio for each, I want you to remember a very, very simple concept here. Okay, so basically, this is the functional unit of any iodinated contrast media, which is a benzene ring with 3 iodines. Alright, so this is how a monomer is going to appear. Right. So, if I ask you that one monomer has 3 iodines, so if there were a dimer of this, how many iodines would be there? Quite simple, there will be 6 iodines. So, whether a compound is a monomer or dimer will determine the number of iodines. When we decide the number of particles, that will be dependent on whether it's ionic or it's non-ionic. Anytime the iodinated contrast media is ionic, it will have one ion and it will have a sodium particle attached. So, in total, there are 2 particles in an ionic media, whereas in a non-ionic media, there's just the single functional unit. Okay, so number of particles is going to be decided by ionic and non-ionic media. Do you agree? So, now when I calculate the iodine particle ratio of different things, it's going to be pretty easy, nothing that I have to memorize. So, when they ask me ionic monomer, iodine particle ratio, because it is a monomer, how many iodines will it have? It will have 3 iodines. Because it is ionic, how many particles does it have? 1 benzene, 1 sodium. So, 2 particles. So, the iodine particle ratio becomes 3:2. When I talk about ionic dimer, a dimer, how many iodines? 6. How many particles in an ionic agent? 2. So, it is 6:2 or 3:1. When I go on to non-ionic monomer, being a monomer, 3 iodines, non-ionic, so only 1 particle. So, the ratio becomes 3:1. When I go to non-ionic dimer, because it's a dimer, number of iodines 6, because it is non-ionic, just the 1 particle. So, now when we analyze the iodine particle ratio, we realize that this non-ionic dimer has the maximum number of iodines and the minimum number of particles. So, this is something which is going to have the least osmolarity. Somewhere this osmolarity is iso-osmolar to the plasma, and hence these contrast media are called iso-osmolar. They are the safest in renal failure. When we talk about these two which have the same iodine particle ratio, they also happen to have the same osmolarity of 600, and they are referred to as low osmolar contrast media because relative to the ionic monomers which have an osmolarity of 1200, which are called high osmolar contrast media, these are much lower, and hence the misnomer that it's LOCM, it's low osmolar, whereas we have a contrast media which is even lower than it. Okay, so these are the various osmolarities that we want to remember. Talking about examples, remember anything which is ionic is going to end with 8. The name is going to end with 8 because it's a salt, whereas non-ionic and alcohol will end with ol. Okay, so that is how we can identify. Ionic monomer, the compound I want you to remember is called diatrazoate. Okay, the compound ionic dimer I want you to remember, ioxaglate. One trick, anything apart from ioxaglate which ends with 8 is there in your option, it goes here. It's an ionic monomer. Alright, so remember this trick. Non-ionic monomer, most common, iohexol, which comes under the trade name of Omnipac that we had seen. Non-ionic dimer comes as iodixanol or the trade name of Visipac. One more trick, any compound that ends with OL given in your option which is not iodixanol will be non-ionic monomer. Okay, so you can remember that trick. So these are all the iodinated contrast media that we want to remember. Now let's talk about contrast induced nephropathy. Now the iodinated contrast media have this adverse effect of producing nephropathy. Alright, they have this adverse effect on the kidneys. So now how is it defined? So contrast induced nephropathy is defined as an increase in the creatinine by more than 0.5 mg per dl absolute increase, or if we know the baseline value, there is a relative increase by 25%. Okay, so 25% or 0.5 increase within 48 hours and you have ruled out any other cause of this acute nephropathy, acute kidney injury. So any other cause has to be ruled out and these are the values. It has to happen within 48 hours of contrast administration and this is called CIN. So now how to prevent CIN? So if you have a patient who already has diabetes or hypertension or is on nephrotoxic drugs who has an increased risk of CIN, how will you prevent it? So the only evidence-based medicine method proven to reduce the risk of CIN is actually hydration. Alright, so hydration or pre-hydration before the patient gets the contrast, pre-hydrating the patient is something which is the best method proven to reduce the risk of contrast-induced nephropathy. And when we have to choose the contrast media, as we saw, we are going to prefer non-ionic over ionic because they have a lower osmolarity, right? So we are going to prefer non-ionic media over ionic media. Going ahead, so out of all the IV contrast media, remember iodinated gadolinium, not safe in renal failure. This one causes contrast-induced nephropathy if given in patients with renal failure or deranged renal parameters. Gadolinium when given in renal failure is even more harmful. It causes a phenomenon called NSF, which stands for nephrogenic systemic fibrosis. Alright, so it causes nephrogenic systemic fibrosis. But SonoView, which is the ultrasound contrast media, consists of microbubbles. So this is actually made up of sulfur hexafluoride gas in a phospholipid shell. So these are these tiny air bubbles. Because they are excreted through the lungs, remember it is safe in renal failure. It's the only IV contrast agent that's safe in renal failure. Remember this. Now let's talk about two parameters which determine the X-ray features. Alright, so one we have KVP and one we have MAS. So here I just want you to remember the relationship. So KVP basically kilo voltage peak determines the voltage difference between the cathode and anode. Alright, and this is something which is directly proportional to penetration. So if you have an obese patient, alright, so and they ask you what is the parameter that you will have to change, you will say that I will need to increase the KVP because we need to increase the penetration of X-ray beams because now there is a larger surface area at play. Alright, so that is something that we want to do. And the other relationship will be that it's inversely proportional to contrast. So whenever you increase KVP, the contrast will reduce in turn. So now if we keep the same example going of this obese patient, he's come to you for an X-ray, we have increased the KVP because penetration increasing is a must. Now in that process, we have made the contrast of the X-ray very low and that is something which is not acceptable. So how do we work around it? So we have another tool which is MAs, which is milliamperage second. So if you remember, ampere is the unit of current. So this actually determines how many number of electrons are actually coursing from cathode to anode, and this determines, this is directly proportional to the contrast. So can I say in this obese person, where I want to increase the contrast, the other parameter I can also increase is increase the MAS. So you increase the KVP also, you increase the MAS also, and you can in turn make up for the contrast, right? But overall it determines the blackening. If I go on increasing the MAS, it becomes more and more darker overall. Okay, so when asked what is the best determinant of contrast, it will be KVP. Remember, KVP is the chief determinant of contrast. MAS is just a secondary parameter that we can use in such cases to compensate. Alright, so now talking about lead apron, again a question that figures in very commonly. So this is how it looks. This is a lead apron. The minimum thickness by AERB that this lead apron must be is 0.25 millimeters, and most commonly, remember, we use a thickness of 0.5 millimeters. Similar to the lead apron, we have lead gloves, we have lead goggles also, which are used to shield basically the workers from radiation. Apart from that, one more tool to monitor the amount of radiation exposure to radiation personnel is this instrument called TLD badge. It's a personal dosimeter that every radiologist, radiographer will get. This is called TLD, which stands for thermoluminescent dosimeter. So that stands for thermoluminescent dosimeter based on its principle of thermoluminescence, where it undergoes this luminescence when we heat it up. Alright, so this is the badge that everybody gets, and you're supposed to wear it on your collar above the lead apron or below it. So obviously, logically, we have to wear it below the lead apron so that we know that after the lead apron protection, how much exposure am I getting, and that gets calculated, right? So it's worn below the lead apron, remember, at the collar level. And what is the compound that it is made up of? Remember, it is made up of calcium sulfate, which is loaded with dysprosium. This is what it is made up of in India. Apart from this, lithium fluoride can also be used. There's one more option that we have, but this is what we use in India. And remember, this dosimeter every 3 monthly we have to send it, alright. So every 3 monthly the calculation happens that this is the radiation that you've been exposed to. Alright, so this is the usage of personal dosimeter or a thermoluminescent badge. Now let's quickly go through the thumb rules for various investigations. So we've been talking about X-rays. Remember, X-ray, something very routinely available, will be the initial investigation for any emergency, right? For all orthopedic pathologies, X-ray remains the initial investigation of choice, whether it's fractures, evaluating foreign bodies, evaluating bone tumors. And to know the position of medical device, again X-ray is the investigation of choice. So now again, if you are seeing here, the one thing that I have told you never to miss, this is free air under the diaphragm, pneumoperitoneum, any emergency, X-ray will be your initial investigation of choice. Going ahead to CT. So on CT, we have various Hounsfield units that we need to know. So now talking about Hounsfield units on CT. Alright, so this is a measure of the density. In turn, how black or how white a structure is going to look on the CT is going to be determined by the density of that compound, by the density of that substance, and that can be given a numerical value in Hounsfield units as described here. Okay, so these are the 4 values that we have. Air, yes, it is the blackest. So anywhere you see a negative HU, that means that it's going to be hypodense. It's going to be black in general terms, right? So air is the blackest thing that you will see. It's the most hypodense thing. It is definitely minus 800 to minus 1000. Fat is not 0 to 20. So fat is again the other thing with a negative HU. There are only 2 things which have a negative HU. One is air, the other is fat. So fat is going to have an HU of somewhere around minus 20 to minus 100. Okay. Whereas air is going to be minus 800 to minus 1000. Okay. So these are the HUs that you can remember. So this is wrong. Acute hemorrhage is going to be hyperdense. It's going to be white. So it will have an HU of 80 to 90. This bone is going to be very, very white, hyperdense, which have this high Hounsfield unit. So just to represent it on a scale, remember the reference is going to be distilled water. So this is distilled water which is this kind of color, which is this kind of density. So can I say, if this is the reference, anything which is whiter than this, anything which is brighter than this will get a positive Hounsfield unit. Anything which is darker than this, you will get a negative Hounsfield unit. So here I am showing you two cross sections of the CT. Let's try and evaluate. So two things which are black, which are hypodense. One is the air. So this air here will have a Hounsfield unit of -1000. There's -10 to -100. This is the fat that you are seeing, subcutaneous fat, mesenteric fat, again quite hypodense. So remember this very, very important concept, and on the basis of this, if they show you a renal tumor with this hypodense thing or a negative Hounsfield unit, will you be able to guess the mass? Yes, a renal mass with fat, angiomyolipoma. Similarly, if you see a mediastinal mass with fat, calcification, think of a teratoma. Okay, so that is how we can approach. When we go to 20 to 30, remember now we are into the positive side of things. We are into positive, brighter things. Okay, so 20 to 30, it's going to be the muscles and the soft tissue. So muscle, soft tissue have a Hounsfield unit of 20 to 30. 60 to 90 will be acute hemorrhage. So remember, acute hemorrhage is much more hyperdense than soft tissue, and that is why anytime we want to look at acute hemorrhage, we will do a non-contrast CT as investigation of choice. Remember this thumb rule. 200 to 300 will be the contrast that we inject. So whenever you see vessels appearing white, that is the contrast that we have administered into the IV circulation, which has this high density. And the thing which is the whitest or the brightest will be the bones or calcification, which will have a Hounsfield unit of 1000. So if you look at the bones here, anytime this is a starting point, you see the bones are white, it's a CT. Okay, so bones calcification will be hyperdense. And if you have a metallic foreign body that even exceeds this range, alright, so it will be whiter than bone, it will be so white. Okay, so remember, metallic foreign body also hyperdense. So now based on this, can I say non-contrast CT can be used for anything which is white, anything which is a positive HU or basically appears bright on a CT? Yes. So one, anywhere I want to look at acute hemorrhage, anywhere I want to look at calcification, anywhere I want to look at bone, particularly the cortex of the bone is going to be very, very hyperdense, right? Not the medulla. So anytime I want to look at cortex, it will be this. So based on this, let's see. For head and spine trauma, I want to see fractures, I want to see acute hemorrhage, NCCT, investigation of choice. Acute subarachnoid hemorrhage, again acute hemorrhage, NCCT. Calcification, whether it's intracranial or it's in the form of renal calculi, we again want to rely on NCCT. Then I want to look at a foreign body, a metallic intraocular foreign body. Remember, investigation of choice, NCCT. So just a disclaimer, intraocular foreign body, very important question. So initial investigation for any foreign body, remember, was X-ray. Investigation of choice, CT. What is contraindicated is what I want to know. So remember, MRI is contraindicated in suspected cases of intraocular foreign body because MRI is a magnet. When you have a metallic foreign body in your eye, that is going to be attracted to the huge magnetic field and it can cause irreversible damage to the patient, and that is something that you must be very, very careful of. So remember, never ever do MRI before ruling out any sort of foreign body. Okay, that is a life lesson for everybody. Okay, going ahead, I want to see cortex, I want to see fractures, except for stress fractures, which will be best diagnosed on MR. Everywhere else, NCCT. Anytime I want to look at stroke, initial investigation in stroke, the first thing when we want to rule out a hemorrhagic stroke, answer will be NCCT again. So this is the order, very, very important thumb rule for NCCT. What is this CT? So this is a CT which is showing you a high resolution CT of the lung. Here I want you to remember two thumb rules. HRCT lung is the investigation of choice for interstitial lung disease, and it's also the investigation of choice for bronchiectasis. And this is a question that has been repeated over and over again. So now let's just quickly learn the difference between how to recognize a CT scan and an MRI. Alright, both of them you will be given axial sections. Predominantly the head scans, you need to know how to differentiate them very well. Okay, so first starting point, very simple. Always look at the bone. So if you find that the bone is hyperdense, right, you know that it's a CT scan. And if you find that the bone, particularly the cortex, alright, look at the cortex. If the cortex is black, then it is MRI. Okay, so that is how we basically use our approach to distinguish whether it's a CT scan or MR based on the density of bone. If bone is white, CT, bones are black, it's MR, as simple as that. So now in MRI, we further have various sequences. So here we have two main sequences, which is the T1 weighted sequence, T2 weighted sequence. How to identify? Again, very simple rule, which is World War II. So on a T2 weighted sequence, you will have water as white. You will have the CSF appearing hyper intense as you are seeing here. Okay. Then when we look at the gray matter, white matter on a T2 weighted, can you notice here how the gray matter is hyper intense? It is whiter, while white matter is hypo intense relatively. But on T1, the fluid, the CSF is going to be dark. The CSF is going to be dark, but the gray matter, white matter will follow its name. So you will have that the gray matter is indeed gray or hypo, whereas white matter is indeed bright or hyper intense. So it follows its name. So one trick to remember here is anytime you want to look at any pathology, it will elicit edema. So what is my sequence of choice when I want to see pathologies? It's going to be T2, right? So remember, T2 is the sequence of choice when I want to look at any edema, any pathology, right? But there are certain things which are T1 bright. Most pathologies T2 bright, but a few specific things are bright on T1. So what are those substances and then the related pathologies? First thing, melanin. Remember, melanin and hence all melanomas will be T1 bright. Anything which is very rich in protein. So anything which is rich in protein like keratin. So when you have keratin containing lesions like craniopharyngioma, or there are keratocystic odontogenic tumors in the jaws which are called KOTs, will also be T1 hyperintense. Cholesteatoma again will be T1 hyperintense. Epidermoid cyst again will be T1 hyperintense. This is a very useful list that we are building here. All of these tumors will be T1 hyperintense, and that's a very useful diagnostic feature. Apart from that, remember, posterior pituitary also has neurosecretory granules that make it posterior pituitary hotspot on T1. So it appears as a white spot on T1, whereas the anterior pituitary will be dark. So this is referred to as posterior pituitary hotspot. Apart from this, also remember, gadolinium will be T1 bright. So anytime you give gadolinium, you do a T1 weighted sequence. Alright, so this is the gist of T1 versus T2. Coming to the thumb rules for MRI. So remember, MRI has a much better soft tissue resolution. Do you see the soft tissue contrast resolution? It's much better than CT. So anything that I want to evaluate in the brain, any brain pathology or any spine or any nerve pathology, anything to do with the central and peripheral nervous system, my answer will be MR. Alright, so brain tumor, spine tumor, nerve tumors, MR. Pancreas tumors involve the brachial plexus, right? So if I want to see the nerves again, brachial plexus, MRI. If I want to see posterior mediastinal mass, remember all the other mediastinal masses, CT is the investigation of choice. But posterior mediastinal mass, the most common posterior mediastinal mass is actually a neurogenic tumor. And that is why, because again, a nerve, answer will be MRI. Chronic SH. So again, now changing gears into hemorrhage. So we just discussed that acute hemorrhage is going to be hyperdense on CT. So anytime I want to see chronic SH, remember MRI is the answer. Diffuse axonal injury. Again, one exception to head trauma. If you remember head trauma, investigation of choice, NCCT. But one exception is diffuse axonal injury where CT can be normal and you need MRI, particularly a gradient sequence called susceptibility weighted imaging. And for stroke, again, initial investigation of stroke is going to be NCCT. But when you want to know the investigation of choice for ischemic stroke. So for hemorrhage, we could see NCCT. But for ischemic stroke, answer is going to be diffusion weighted imaging in MRI. So MRI or diffusion weighted imaging in MR is the most sensitive investigation. Apart from this, when we talk about orthopedics, we saw cortex CT, but bone marrow pathology or bone marrow edema in osteomyelitis, MRI. Any ligament, any cartilage, any spinal cord or IV disc pathology I want to see, I will do MRI. Soft tissue sarcomas, again MR. Choledocholithiasis. So remember, for CBD calculi, again you want to rely on MRI as investigation of choice, but here remember the gold standard is going to be ERCP, right? Because it can diagnose as well as treat. And remember one more thing, CA rectum, investigation of choice for staging is going to be MR. So these are the thumb rules for MR that we want to remember. So now talking about ultrasound. So remember, on ultrasound, basically we again do not use ionizing radiation. We use sound waves. So we use something called as piezoelectric crystals here, alright? We use piezoelectric crystals which are made up of lead, zirconate, titanate, alright? So PZT, lead, zirconate, titanate are the crystals that basically we use in these probes. So what these crystals will do is, the electrical energy that the probes are getting, will convert it. These crystals will vibrate and they'll convert into sound waves. Alright, so they'll convert it into sound waves, and these sound waves are emitted from the probe into the body, and that is what we'll see as images. Okay, so all of these probes are used depending on the frequency of the vibration, and that is how we use various applications. So here you have a low frequency probe which is a 2 to 5 megahertz. One more fact to remember, what is the frequency of medical ultrasound? So it ranges from 2 to 20 megahertz that we use. So here the low frequency probe 2 to 5 megahertz. So remember here, frequency of the probe is directly proportional to the resolution, and it is inversely proportional to the depth. So when I have a low frequency probe, it's going to offer me a deeper view, but it will have relatively lower resolution. Okay, so when I want to see deeper structures like the abdomen or like the pelvis, alright, so we will use a curvilinear probe. On the other hand, this is a high frequency probe, 16 to 15 megahertz, right? So this is 16 to 15 megahertz, wherein you get a higher resolution, but the superficial structures can be evaluated. So anytime I want to evaluate the thyroid, the scrotum, or the breast, alright, so all superficial structures are evaluated with the linear probe. This is the linear probe. We have 3 more probes which you need to know. So this, as you can see, is shaped like this. So this is an endocavitary probe which can go into cavities, such as transvaginal sonography. So this can do TVS and this can do transrectal sonography. Alright, so these 2 sonographies can be done with this special endocavitary probe. This is a phased array probe which is used for echo. So this is also called as echo probe at times, but it's called a phased array probe. Again, it is a low frequency probe which can again have a very large depth. So this is used to evaluate the heart, and it has a small footprint. Do you see how it has a smaller footprint? So it will fit in the intercostal space. If these are the 2 ribs, so this small footprint of the probe will fit into the intercostal space. And finally, when we see this, this is shaped like a hockey stick. So this is a recent advance where we use this hockey stick probe for various musculoskeletal applications like nerve imaging and all. Okay, so this is the hockey stick probe. Again, it's a high frequency probe. Okay, so these are the various probes. Now 2 artifacts I want to show you on ultrasound which are very, very useful. So when you see this kind of an appearance, where this is the gallbladder, and within the gallbladder you have this very white hyperechoic structure which produces what? Behind it. Do you see there's this shadow behind it? So this is referred to as posterior acoustic shadowing, which would be produced by any dense structure. So any dense structure like air or calculi, remember, or bone, It's basically gonna produce shadowing, where bone and calculi will produce this pitch dark shadow, while air will produce these dirty kind of shadowing, that is referred to as dirty shadowing. So all three of these produce this posterior acoustic shadowing. Okay, this is something which is very useful for visualization of GB calculi, and that is why investigation of choice for GB calculi is going to be ultrasound. On the other hand, look at this, the completely black structure, which is called an anechoic structure, right? It is not having any echo, so black, anechoic. But look behind it, it's producing this brightness, which is called posterior acoustic enhancement. Just like you saw shadowing, the exact opposite is posterior acoustic enhancement, which is seen in cystic lesions. Anything which is filled with fluid will show you this appearance. So coming to thumb rules for ultrasound. So remember, gallstones, ultrasound is the investigation of choice. In case they ask you most accurate, alright, so highest sensitivity plus specificity theoretically is in the HIDA scan, but investigation of choice, ultrasound. Acute cholecystitis, again ultrasound. Any kind of fluid we want to see, any cyst or any fluid, again ultrasound. So hydatid cyst of the liver, ultrasound, investigation of choice. Minimal pleural pericardial effusion, ultrasound. We want to see hemoperitoneum. So in blunt trauma abdomen, we do the FAST scan, right? Now we do the EFAST scan. So remember, ultrasound. Pregnancy, again we want no ionizing radiation, so ultrasound and MRI at our disposal, out of which, because ultrasound is more readily available, so when faced with an emergency situation in pregnancy, that would be your go-to investigation. And also remember, in children, in CHPS, which is congenital hypertrophic pyloric stenosis, or IHPS, again ultrasound is the investigation of choice. Quickly looking at all the machines. So whenever you see this tunnel, this very long tunnel, this is how an MRI machine is gonna look. When you see this gantry, a smaller sort of a tunnel, wherein this table is gonna go inside this gantry, which consists of an X-ray tube, and you have a series of detectors here. This is how a CT scanner looks. Okay, so this is your X-ray machine, wherein you have a standing detector, and you have this lying down detector for supine use as well. Okay, so this is an X-ray machine, and when you see this C-shaped unit, wherein the X-ray tube and the detector can move in any direction, 360 degree. This is called a C-arm fluoroscopy unit. So this is a video of the X-ray. So this is a C-arm fluoroscopy unit that can be used for fluoroscopy interventions or digital subtraction angiography. Okay. Similarly, there's a machine you must have seen in your life. This is an ultrasound machine. This is a mammography machine. This is something which is very important image, wherein you see these compression paddles. So this is the X-ray tube, and these are the paddles you'll use for compression. Okay, so this is the mammography unit, and here what you can see is the DEXA machine. Alright, so when you see this kind of an appearance, this is a DEXA scanner, which is the investigation of choice for osteoporosis. So dual energy X-ray absorptiometry for osteoporosis. Finally, talking about a few important radiation values that you need to remember. So now this is the most important one. What is the radiation of chest X-ray? Is one value that you must memorize, the 0.02 millisieverts. Especially in today's time when there's so much controversy going on in how much radiation a CT has as compared to X-ray, right? So here you have the numbers right in front of you. So chest X-ray 0.02 millisievert. When we talk about CT, it will depend on the volume of the part. So CT head 2 millisieverts. So that is equal to 100 chest X-rays. Can you see this? Whereas a CT chest is double of that. So a CT chest is almost equivalent to 200 to 250 times chest X-rays, right? So that is the relation that you need to remember here. So CT chest 5, whereas CT abdomen will be 10 millisieverts. Abdominal X-ray has a lot of radiation as compared to chest X-ray. So does a skull X-ray. Okay, so these are two values which you need not remember. The ones which are highlighted are important. And remember, mammography is 0.5 to 0.7. This is also something which is important. Okay, so a mammography has 0.5 to 0.7 millisievert radiation. A PET has, because a PET CT usually will have a full body CT which is done along with the PET. So we usually do a hybrid PET CT. So if both PET and CT are done, it will have the maximum radiation, wherein it will have PET ka 10 to 12 millisievert plus the whole body CT ka around 10 millisieverts. So it around 20 to 25 millisieverts in total. Okay, so remember this will have the highest radiation exposure. A barium meal follow through will have 7 to 8 millisieverts. So this is also too much. So when we compare it, it's almost equivalent to CT abdomen. That is why in today's time, these barium investigations are very rarely performed, okay, because of this very high radiation. IVP is 2 to 3. It's okay if you don't remember this. So the highlighted ones are very important. So this was a quick recap on general radiology. So now we continue with the portion of musculoskeletal radiology. Here, the first thing we are going to discuss are bone tumors. Alright, so anytime you look at a bone tumor in a question or otherwise, you first have to build a pattern-based approach. Alright, so the age is going to be very important, the bone which is involved is going to be very important, and finally, where in the bone is it located? Okay, so let's begin with this part of the discussion, wherein let's see if it is within a long bone and what part of the long bone is the tumor lie. Does it lie in the epiphysis? Does it lie in the metaphysis, or does it lie in the shaft of the bone? And this will help us narrow down a lot of these differentials. So when we talk about epiphyseal tumors, remember the mnemonic ECG. Alright, so epiphyseal tumors, you need to remember two tumors here. Okay, so the first tumor is going to be chondroblastoma, and the second one is going to be a giant cell tumor. Okay, so now a chondroblastoma, remember, will be seen in a child, C for a child, wherein the growth plate is not yet fused. So that is one more way to look at the age while looking at the radiograph, that the growth plate is not going to be fused. So the growth plate is not going to be fused. Whereas in a GCT, it is usually seen in a middle-aged adult. Alright, so it will be seen somewhere between 20 to 40 years of age, wherein the growth plate is going to be fused. Okay, so this is how we distinguish chondroblastoma from GCT. So now let's look at the images. So here, when we remember epiphyseal tumors, two things, chondroblastoma and giant cell tumor. So right here, if you see this is a child, you can see that the growth plate here is not fused. You can see that the epiphysis is yet to fuse with the metaphysis. Okay, so this is an example of how a chondroblastoma would appear. Do you see this epiphyseal lytic lesion, which is very well defined? A lot of times you can also find calcification here, which pathologically is described as chicken wire calcification. Okay, so this is chondroblastoma. On the other hand, this is a very favored site of a GCT, which is the distal end of radius. Okay, so this is again something which will be a big clue if you see this in the exam, wherein you see this. First of all, skeletally mature adult, growth plates are fused, and you see this typical soap bubble appearance, right? So you see the soap bubble appearance in the tumor, which is extending from the epiphysis growing towards the metaphysis. Right, so this very typical trabeculations that you see, soap bubble appearance, is indicative of a giant cell tumor. Going ahead to diaphyseal tumor. So when we talk about diaphyseal tumors, remember the three vowels. So all the three vowels are sticking together in the diaphyseal region, and you would have these three differentials. So A for adamantinoma. Alright, so A for adamantinoma, E for Ewing's sarcoma, and O for osteoid osteoma. So these are three lesions which are all diaphyseal in nature. Okay, so let's have a look at the first diaphyseal tumor. So here, when they give you that the person can belong to any age, so it can be an adolescent or a middle-aged adult who has nocturnal pain which is relieved on NSAIDs. So this is a typical history that you will get here in the case of osteoid osteoma. So when you hear this clinical history, you look at the X-ray and what do you find? You find that there is a diaphyseal lesion, there is a shaft of a long bone here, and you can find that there is this sclerotic region, right? So there is a cortical based lesion here that you are seeing, which is predominantly eccentric towards the cortex and has this central lucency. So this central lucency that you see here is referred to as the nidus. Alright, so this is the central nidus with a predominant solid periosteal thickening, and it is cortical based. So all of these features go in the favor of an osteoid osteoma. And why does he have this typical scenario? It's because this nidus, this central lucent nidus that you are seeing, it actually releases prostaglandins, and because of the direct blockade of NSAIDs of these prostaglandins, the pain gets relieved. And remember, the treatment of choice for osteoid osteoma, it's going to be CT guided radio frequency ablation. So under CT guidance, we'll basically put a probe into the nidus and we will ablate it using radio frequency waves, and this treatment is called CT guided radio frequency ablation. So looking at the next diaphyseal tumor, here you will get a history of a young child 0 to 20 years of age, more commonly in the first decade relatively. So the history will have that the child has fever, the child has a swelling which has erythema, a large soft tissue component, which will make you think is it infective or inflammatory. But when you look at the X-ray, you would find that there is this large permeative lesion. So it's such a destructive lesion, it infiltrates into the bone. So this is called a permeative diaphyseal lesion with an incomplete periosteal reaction. Do you see these lifted up bone which have these lamellae? So this is referred to as the onion peel periosteal reaction, and look at the large soft tissue that you are seeing. All of these features go in the favor of an Ewing sarcoma. So remember the second diaphyseal lesion after osteoid osteoma, Ewing sarcoma, very aggressive lesion, aggressive periosteal reaction in the form of onion peel. Or one general principle that you have to remember, onion peel reaction, sunburst reaction, Codman triangle, all of these are examples of aggressive periosteal reaction. It doesn't mean that it's Ewing sarcoma equals onion peel and osteosarcoma equals sunburst or Codman's. It can be interchangeable. All of these periosteal reactions tell us one thing, that the tumor is growing at a very quick rate. It's an aggressive tumor. Alright, so this is Ewing sarcoma. Now the third one, a rarer tumor that you will have, wherein tibia is the chief bone which is affected, right? So tibia is very typically involved in this tumor, which is adamantinoma. Alright, so when you have a tibial diaphyseal tumor with associated bowing of the bone, you find that the bone is bent and it does have malignant potential. Alright, so this is how adamantinoma appears. It has these lytic sclerotic areas associated with bowing of the bone. Adamantinoma, a rarer lesion. And also remember the histopathological counterpart. Same histopathological features that we will see in adamantinoma will also be noted in ameloblastoma of the jaw. Okay, so remember, ameloblastoma in the jaw will have the same histopathological features as in adamantinoma. Talking about metaphyseal tumors next. So here again a very typical example of where a proximal humeral end would be given to you, and you see this very well defined geographical lytic lesion. Okay, and what is this fragment? You see that there is a pathological fracture here and the fragment is fallen into the lesion. Alright, so this is referred to as the fallen fragment or the fallen leaf sign, and in the first decade, no septations. This is a simple bone cyst. So metaphyseal lesion, centrally located, associated pathological fracture, no septations, simple bone cyst. On the other hand, second decade or older patient with multiple septations. Alright, so you are finding that now it's no longer a simple cyst. There are these multiple trabeculations that you are seeing within the lesion, again giving you a soap bubble kind of appearance. This is an aneurysmal bone cyst, and when we do the MRI of an aneurysmal bone cyst, what are we going to find? Remember, we are going to find multiple blood levels. Alright, so blood or blood fluid levels, which tell us that there is some sort of bleeding which is going on inside the lesion. Okay, so these levels, which are your blood fluid levels or fluid levels, variably referred, will have these multiple pockets, will have these multiple locules, and within these locules you will find that there are these multiple levels which are getting formed. Alright, so you will have these levels of fluid which are getting formed, and whenever we see these kind of fluid levels, these are all our differentials that we need to consider. So one, aneurysmal bone cyst has to be ruled out. Secondly, a giant cell tumor, again which had trabeculations, epiphyseal tumor can also have fluid levels within. One very important variant of osteosarcoma is this telangiectatic OS, which again has bleeding within it. So as the name suggests, this is one variation, one variant of osteosarcoma with fluid levels and metastasis. What kind of metastasis? Again, mets which are very vascular. So remember, hypervascular metastasis again will show us these fluid levels. Predominantly primaries like RCC, clear cell RCC, which is very vascular, follicular thyroid C again, which is very vascular, will show you these fluid levels. Looking at the next entity here, what do we see? We see that there is this bony outgrowth, right? You see that there is this bony outgrowth which is growing away from the joint. So this entity, this is not a true bony tumor. What is this? This is actually an osteochondroma. This is an osteochondroma, also referred to as exostosis, right? So this is osteochondroma or exostosis, wherein we see this lesion which is growing away from the joint outside the bone. Okay, and anytime you see multiple such lesions, it's referred to as diaphyseal aclasis. It's called diaphyseal aclasis, or it's also called hereditary multiple exostosis, HME. Quite a simple self-explanatory name. So now, what is the importance? Anytime it is multiple, remember the risk of this lesion turning malignant increases. So in a single osteochondroma, first of all, what kind of malignancy will it turn into? Osteosarcoma or chondrosarcoma? So remember, it has a risk of developing chondrosarcoma. And how will I pick up that chondrosarcoma? Tell me, how do we look at the cartilage? Is the cartilage visualized on an X-ray? No, not really. So the investigation of choice, if you remember the thumb rules for cartilage, is going to be an MRI. Alright, so when I want to see that this cartilage cap is thickening, it's producing this malignancy, I need to do an MRI to rule out chondrosarcoma, to rule out malignancy, and the thickness we take is going to be more than 1.5, some books write 2. Okay, so 1.5 to 2 centimeters the thickness that we use to say that okay, it might be turning into chondrosarcoma, right? Apart from that, so the risk of this turning malignant is higher in diaphyseal aclasis. So in a standard solitary exostosis, the risk is somewhere around 1%. But when there are multiple lesions, the risk increase from 5 to 20%. Okay, so there is a much higher risk of chondrosarcoma in a familial multiple hereditary exostosis syndrome. Talking about this metaphyseal tumor, something which has the highest chances of getting asked, what do we see? So there is this very infiltrative, permeative tumor in the metaphysis, which is growing from the bone. You see this periosteal reaction and this lifting up. This lifting up of the periosteum is referred to as the Codman's triangle. And you also see these new bony spicules which are growing perpendicular to the bone. This is called as the sunburst reaction. Now, what is the Codman's tumor? Remember Codman's triangle versus the tumor. So, Codman's tumor was our epiphyseal tumor starting with a C. So, that is chondroblastoma. So, it's chondroblastoma which is actually called the Codman's tumor. Do remember this trivia. Okay, so this is your aggressive metaphyseal tumor. How do I know it's osteosarcoma? It will have this dense matrix. You see how dense it looks? That is suggestive of new bone formation. Right, so this is how osteosarcoma will appear. The age group is again 0 to 20 years, more in the second decade. Okay, so this is about osteosarcoma, a very important image. So now looking at this set of images in this MCQ, what are we seeing? We are seeing that the hand bones are completely deformed. All the hand short tubular bones are affected and a few of them are expanded and they have this very stippled sort of calcification. Can you see they have these white foci? In addition, what do I see? I see that the soft tissue has these multiple bluish lesions. So in this context, this is likely to be hand enchondroma. So anytime you're shown the X-ray of the hand and you see the tubular bones getting expanded, it may be a solitary lesion or multiple lesions. That is suggestive of enchondromas. Again, chondro meaning cartilaginous matrix, so it will have calcification which is very stippled, dotted, so that is the hallmark of enchondromas. Short tubular bones of the hand will be a very big clue. And now when I see these hemangiomas, these bluish lesions actually represent hemangiomas. So now when I see the clinical picture, I see these bluish lesions. So these are actually hemangiomas. A lot of times on the X-ray itself, you will see these calcifications, these soft tissue calcifications which are called as phlebolytes. So these are seen in hemangiomas and vascular malformations which are vascular calcifications. Alright, so these are phlebolytes that you are seeing. So enchondromas, plus soft tissue hemangioma constitutes the Maffucci syndrome. Okay, so anytime you see these multiple enchondromas, again see this different X-ray, can you see the short tubular bones of the hand being expanded with these dots, with these stippled sort of calcification? This is the hallmark of enchondroma. And when you see only multiple enchondromas, so O for only multiple enchondromas, it is O for Ollier's disease. Wherein if you see multiple enchondromas, in addition there are these soft tissue hemangiomas like the last case, that is called as Maffucci disease. Alright, so that is called as Maffucci. So remember the two syndromes with multiple enchondromas. Going ahead, anytime we see a ground glass matrix, so particularly the femoral neck is the region, the femoral metaphysis is the region that gets affected here. So whenever you see this sort of a matrix wherein you have this not very white, not very black, so it's not a lytic lesion, it's not a very sclerotic newborn forming lesion, it's in between. So this is called as ground glass matrix. And if again you have a pathological fracture which is associated with it, you will see this deformity wherein the femur is bent. It's bent like a Shepherd crook. So this is called as Shepherd crook deformity. And the lesion that it typically describes is called the fibrous dysplasia. So this is fibrous dysplasia. And one more sign we will see here is called the Rind sign. And this Rind sign describes this sclerotic rim. Do you see this lesion again in the femoral neck which has this sclerotic rim around it? So a central ground glass matrix and a rim around it, the Rind sign, all features of fibrous dysplasia. Now again, fibrous dysplasia can involve multiple bones. So a polyostotic FD is associated with two important syndromes that I want you to know. One, when they give you associated history of precocious puberty, endocrinopathies, I want you to think of McCune-Albright. So McCune-Albright syndrome will have this associated anomalies. On the other hand, when you see multifocal soft tissue myxomas, this is something which is seen with Mazza-Broad's. This is something which is seen with Mazza-Broad syndrome. Okay, so remember these two syndromes which are associated with polyostotic or multiple fibrous dysplasias. Now, looking at the vertebrae, so remember the most common benign lesion of the vertebral body is this lesion, which is the spinal hemangioma. So here we will see these two signs. When I look at a sagittal image, you will see that all of these bony trabeculations are prominent. So this is described as the jail bar or a quadroid cloth appearance. If I take a cross section through this, again you will see the bony trabeculations getting very prominent. This is referred to as the polka dot sign. Okay, so these are two signs which are seen with spinal hemangiomas. So now starting with arthritis. So here again I'll give you the hallmark features that you have to look out for in the radiology and the diagnosis becomes pretty evident. Again, clinical picture will be very important here. So we'll try to incorporate everything. Okay, so when you have this sort of an image wherein the large joints are affected more than the small joints, you have a clinical picture wherein there is this chronic history, large joints getting affected, it is quite asymmetrical, there is no morning stiffness. All of these features tell you that something degenerative is happening, right? So now we are discussing osteoarthritis. Alright, so now let's discuss the features of osteoarthritis or degenerative arthritis. So in this, first of all, the larger joints are going to be affected. There's going to be asymmetrical involvement. So asymmetricity will be in the sides as well, wherein right and left will not be completely symmetrical. Plus, the joint that is involved will also be asymmetrically involved, wherein you don't have a symmetrical complete joint space reduction. You find here that the lateral part, the lateral joint space is more involved rather than the medial joint space. So that is how it will be asymmetrical within the joint as well. Apart from that, you will find that there are new bones which are formed, which are called osteophytes. So these triangular projections that you are seeing, that is called as osteophytes, which is new bone formation. And also you will find around the bone, do you see this whiteness here? This is called subchondral sclerosis. So asymmetrical involvement, large joints getting involved, subchondral sclerosis and osteophytes. All of these are hallmarks of a degenerative disease such as osteoarthritis. Exact polar opposite when you have a younger female with a history wherein she has morning stiffness, wherein there is stiffness and it improves with activity, worsens with rest, all of these features tell you what? That we are dealing with an inflammatory arthritis. And when we look at the imaging, again we would find the small joints getting involved more frequently. X-ray of the hand would be given, wherein the most common joint to be involved in inflammatory arthritis, the prototype of which we are discussing, that is rheumatoid arthritis, most common joint to be involved is metacarpophalangeal joint. So they'll give you the X-ray of MCP joint, or they'll give you the X-ray of the wrist. Okay, so here we'll find that the joint space involvement, the joint space reduction, the bones to be involved, it's very symmetrical, all the bones are involved. Plus, in contrast to the osteophytes seen in degenerative arthritis, here we are seeing erosions. We are seeing that the bones are all eaten up. There are these various eaten up areas which are referred to as erosions, which are marginal. So you see erosions at the margins here. Plus, instead of subchondral sclerosis that was happening in osteoarthritis, here you would find that the bone density goes low. Because of the constant inflammation, you have synovial proliferation, which is called as pannus. Because of the hyperemia, you have the bone density getting lost. So that is why you will have this periarticular osteopenia here. Okay, and also the hallmark, the joints to be spared here will be DIP. So remember, DIP sparing again goes in favor of rheumatoid arthritis, and eventually in long-standing disease you will find deformities. So deformities such as swan neck, Bottomnose deformity, Z deformity, all of these will be seen. Hitchhiker's thumb, windswept deformity. So these are all the terms that we study in medicine which are associated with rheumatoid arthritis in the later stages. So radiological hallmark, symmetrical, marginal erosions, periarticular osteopenia. Going ahead, so this is a special view that we do for rheumatoid arthritis, which is called the ball catcher's view. So this is a ball catcher's view wherein the hands are kept like this, such that the joint which is most commonly affected, which is the metacarpophalangeal joint, becomes quite prominent. So you see here that these joints are best visualized on this view, and that is why we do this view for rheumatoid arthritis. One more name that they can give you, this is also referred to as the Bruverton's view. Okay, this is also called as Bruverton's view.